Good afternoon, ladies and gentlemen. Welcome to the Symposium on Clinical Governance. And may I invite Professor Devaka Fernando and Dr. Channa Hewamadama to come and join me at the head table, please. Thank you. In terms of an introduction to the symposium, ladies and gentlemen, clinical governance is a process of quality assurance within health systems. And then we will listen to two of our colleagues from the NHS who will speak to us on the clinical governance process in the UK, and then see how applicable it will be towards a healthcare setting like ours. They will perhaps tell us whether the same 7 pillars would be equally applicable in Sri Lanka, whether there would be other pillars we may have to add on, whether there would be pillars which we may consider not essential within low resource healthcare setting. And it is indeed a great honor and a privilege for me personally to invite Professor Devaka Fernando, my mentor and my guru, to deliver his lecture on clinical governance. Thank you.
Thank you, Arosha. May I also mention that this team's got together after 17 years, and it's an absolute pleasure to deliver this lecture chaired by my house officer at Colombo South Teaching Hospital, and have as my co-speaker the demonstrator, post-intern demonstrator in the department those many years ago. It's indeed a privilege. It's customary to deliver a few conflicts of interest statements in lectures, so I've just put a few of mine, but the conflicts actually are relevant to clinical governance, because in the last 15 years, I've batted around a bit, dabbled in medical management, and in fact in clinical governance. So shortly after arriving in the UK, management sometimes is, some people acquire it, some people have it thrust upon it, and some people are born to it. Let me assure you that it was thrust upon me, because no sensible person becomes associate clinical director 2 years after coming to a new country. And nobody in their right mind takes on the post of assistant medical director to introduce clinical governance to a trust that is failing 3 years after coming to the UK. So I am truly certifiable. So take that in mind when you listen to the rest of my presentation. Since then, I've been involved in management at a different level, but let me assure you that I am a clinician. I still do 4 clinics a week. I still do ward rounds on a ward, and I'm still on call. So I'm not one of these managers. So what is clinical governance? What does it mean? Why do we do it? How do we strive for excellence in professional activity? What feedback mechanisms do divisions and departments where I work have? And how do we manage risk? These are what I would try to cover in my presentation. So I will talk about the parable of the elephant and the blind men, but I realize that elephant conservation and endangered elephant species are endemic in Sri Lanka in more ways than one. So I assure you there's nothing political about this slide. It was done well before last Friday. It's one of the stories from the Buddha's parables, and clinical governance means different things to different people. So what is clinical governance? Essentially, it's a system. It's a system which enables organizations and institutions to do the right thing. It's about creating an environment for people like you and I to deliver excellent services. Now, I'm sure you'll be aware that many of us deliver very good services, but the systems are not up to scratch. This is about developing systems to make them as good as the people who work in them. By the way, this is my plug for the new inductees in clinical fellows, just to get them onto the same wavelength. So if I were to summarize what is clinical governance, it's doing the right thing at the right time, in the right way, in the right place for the right patient. Martin's lecture just established one place where clinical governance is so vital in ensuring the quality of that service. And I understand it's heavily audited and policed. So Arosha referred to the pillars. And these are actually the pillars of clinical governance. And on these, the conceptual house of care is built by putting the roof of governance. So none of this is management rubbish, as many people say. None of this is politics. It's the core of what we do as clinicians. Patient safety can be compromised by a wrong diagnosis, wrong treatment, delays in treatment, errors in treatment or techniques, and of course, faulty equipment. Medication errors, and of course, not involving the patient. So how do we prevent these? How do we mitigate against risk? So we have to deliver safe care by creating an environment, an ambience, where safety issues can be raised, a no-blame culture, to ask what went wrong, not who did what wrong. That's governance. This is achieved by sharing learning from serious incidents, reporting incidents using Datix, which is the tool that we use in our trust, and reflecting on previous incidents as a team, as a multidisciplinary team, not just ourselves. Some of the things that we look at on the ward are pressure ulcers, because we've got fairly dependent elderly patients on some of our wards. We don't like people having falls and breaking bones. As a person who runs an osteoporosis clinic, I'd rather prevent them than involve my orthopedic consultants. And of course, we really don't want to have medication errors, particularly in insulin, which is in my primary subspecialty. And of course, as a trust, we are judged by how safe our environment is by the rates of healthcare-associated infections. So it's not just a government target. This is about patient welfare and safety. And AKI, acute kidney injury, and sepsis are some of the priorities at the moment because they are some of the commonest causes of increased mortality. I won't touch on mortality reviews because my co-speaker is going to touch this very extensively, so I won't mention any more. So how do we manage risk? First, obviously, we've got to look at risk and grade it. So let's do a simple exercise in assessing risk. So this chap's standing barefoot on a metal ladder in a pool of water, handling electric equipment, presumably installing electrical fittings. So pretty risky, but if you stand barefoot, that's really risky, isn't it? So assessing that risk, stopping this from happening through silly rules like saying, wear rubber shoes, don't stand in a pool of water, insulate well. So clinical governance is also silly stuff like that. And many consultants in the UK think it's silly stuff. So what is this built on? Well, it's about how an incident develops. So there are organizational factors, workplace factors, personal factors, defenses, which we put in through our risk management. Unfortunately, sometimes incidents do happen with the best efforts. Why does this happen? Well, it happens because there are holes in those defenses, and this is explained by this thing called the Swiss cheese model. Now, it's not just Swiss cheese. Remember that the cheese is melting all the time in the heat of an overworked NHS. So new holes appear in places you didn't expect. So the risks of something happening, of something going through these new holes and existing holes in the system are very high, and that is risk management. It's a dynamic process. So clinical governance is not a static tool, it's a dynamic process. And it's about risk management. So why do we manage risk? Well, obviously, to make it safer. if I'm the chair of the board of management, I'd say, in addition to that, it's the risk to reputation. We get statutory requirements to do this. We might get fined. Whatever it is, it's still about harm. So how can we manage it? Well, it's a three-stage process. Identify it, document it, assess the chances of it happening again, and put that learning into practice. So this is the fundamental rule of clinical governance. But it gets a bit complicated. So how do we ensure best care and treatment? So some of the things we look at are ensure that the staff are up to date. So we do that through appraisal, see whether we've got our CPD points, and I just got some really good ones on stroke from Martin. So I'll definitely reflect on that in my mobile Royal College app and get my points. And then I put that up when I go for my appraisal. Obviously, the rest of it is self-explanatory. Good record keeping in particular is important because we do a good record keeping audit as a mandatory process in all our wards for all our juniors. They've got to do 5 sets of medical records and reflect on it. So how do we know treatment's effective? Well, there are clinical audits, which are some are national, some are local, and they can be due to general internal medicine, acute internal medicine, or subspecialty. And if you're a trainee in the UK, you've got to do 1 GIM audit and 1 subspecialty audit, because dual accreditation is there to stay, and we'll talk about that later. So there are local audits. So audits are not just something you do because you feel it's got to be done. It's a focused look at what's happening in your service. There has to be an annual audit plan. And these are some of the things that we do, and the prescribing audit is another important one. Antibiotics, more so. What are we trying to avoid? We're trying to avoid never events. Never events are things, as you might imagine, things which should never happen. And these are some of the criteria on which we judge a never event and things we should do. So what are these? Well, there are surgical ones, there's the medical ones, and there are ones in general. So these things should never happen. Zero tolerance. We need to be a responsive service in terms of patient experiences, and these are audited. So forget about the car parking complaints. There are enough complaints or concerns about communication. They didn't know about something. They consented to something that they weren't aware of. All those are important. Complaints are something that we learn a lot from. And in my alternative job, since my partial retirement, I work one day of the week for the Parliamentary Health Service Ombudsman, where we review complaints which patients feel are unresolved by the trust. And there's a lot that can be learned from those. When somebody expresses a concern, it's not a personal criticism. It's a concern. And that's an attitude that is part of clinical governance. Compliments are good. We record them, we reflect on them, we feel good about them. It's not all negative. There's a friends and family survey where you ask people, would you really want your friends and families treated in this hospital? If the answer is yes, I think we're doing a good job. And that's done as a national survey. Is that all? Well, health and safety, which is also thought of as a waste of time, has a lot to do with making the hospital a safe place. And each of these is an induction lecture in itself for staff. I've just compressed some of the slides into this. So all these, and if you're a medical manager in Sri Lanka, you'll appreciate these are what the College of Medical Administrators sorts out. And of course, the annual fire lecture, if you don't go for that, you get docked a year's pay because you don't get your pay progression. Well, it's one of the essentials. If you're a manager or a leader, clinical director, medical director, you are judged on how well you lead. And there are measures of this, which are done externally. The junior doctors feedback on the Junior Doctors Forum. That helps with this. So this is the worst form of leadership, And in my time, I have worked in circumstances like this, but happy to say I'm not there now. And I'm sure all of you have felt that way at some point or the other. So how do we look at these? Well, we look at clinical performance indicators. We design these, we agree on them, and we use them to compare ourselves against centers of excellence or our peers. It's a measure of our own performance by methods we agree on. It's not imposed on us. As a profession, we have the right to do that. And these care quality indicators are fairly straightforward. Now, because this is general internal medicine forum, I've decided to pick some from our acute medicine list of indicators. And these are the ones that they look at. They're not unreasonable, as you will agree. And sometimes, in my other hat, as a member of the governing body of a clinical commissioning board, we use commissioning for quality and innovation tools to incentivize some of these. So basically, we say, if you do well and excel in this, we'll pay you a bit more this year. Give you a bonus, in other words. So this year's ones: acute kidney injury, sepsis, dementia and delirium, antimicrobial resistance, health and well-being. So it's a balanced scorecard. So if you do well on these, that means your local hospital does well. There's a conflict of interest, so I don't do it for Mansfield, I do it elsewhere, 100 miles away. So what are we trying to do? We're trying to improve patient care, use a patient-centered approach, reduce risk, learn from mistakes, and be accountable externally. None of these are bad things. They are not a threat to our independence. I think the most important thing here is it's clinically led. We need clinical engagement. So what is it about? Well, if it's these, every member of staff must recognize their role. So how do we do it in the trust? So in the next 3 minutes, I'll just show some slides about how we do it. Well, these are some of the things we do. They say that managing doctors is like herding cats. Some people try to do it this way, but that's not really successful. People who've tried it have failed miserably. So who is really responsible for all this? Well, nominally, it's the chief executive, the medical director, and the risk management team. So do you think you're responsible? Well, actually, you are. We all have responsibility. What can we do individually? Nothing new there. So each of these might have a bit of mandatory training attached to it. And I don't think any of these would be unreasonable. And there are methods of assessing whether we are doing that correctly and benchmarking us. That's clinical governance. The ability to report safety incident is one, and this is a very important part of it. The ability to report, to discuss it in a non-threatening environment. So remember, if you spot it, you sort it. If you can't sort it, you report it. So I've tried to summarize clinical governance, but it's basically a journey, not a destination. And if any of you fell asleep, that would be postprandial sleep disorder, physiological. If I fell asleep, that's narcolepsy. And so here are some references. I'll leave the slides. I'm very happy for them to be distributed. They are not copyright. They're all my slides. And in terms of how we get clinical governance to work, it's got to be a hands-off growth. Each of these buds will grow on its own if the right soil and the right management climate is there. And that's where leadership comes in. And certainly I've been privileged to work with a medical director who's actually set the stage for this and has brought the trust up very well, nicely. And one of the shoots you notice is mortality, morbidity, which my colleague will be doing. Thank you very much.
Thank you, Professor Fernando. I think we will take the questions at the end of the symposium. May I now invite Dr. Channa Hewamatuma. Channa is a consultant neurologist specializing in neuromuscular disorders at the Sheffield Hospitals Foundation NHS Trust, as well as the clinical audit lead for neurology. Channa, over to you.
Thank you very much, Arosha, for that kind introduction. And I might want to thank the organizers for inviting me today, and also for Professor Fernando, who is also my mentor, as Arosha's, and for laying a nice platform for me to build my talk on. So, as Arosha said, I'm a consultant neurologist by trade. I also do an audit lead role as a mortality lead role for my directorate. If I may draw your attention to this slide, in Sri Lanka, UK had a very interesting health minister who recently said that there are 750 avoidable deaths a month in the NHS hospitals. Now, ladies and gentlemen, this is equivalent to 2 full jumbo jets falling off the sky and perishing every month. If this were to happen in the UK or in Sri Lanka, I do not think people will turn a blind eye to that. People will be very passionate about investigating it and making sure that lessons are learned to prevent it happening again. So, if you stay with the airline industry theory, what are the odds of an aircraft falling off the sky? Is 1 in 1.2 million flights. It's extremely rare. But when this happens, people get very passionate about learning what are the processes which contributed to it and how we can prevent it. I'm sure, like the pilots who try till the last minute to prevent the plane crashing or avoid the unexpected crash, the doctors also do try their very best to prevent harm to a patient. But sometimes incidents do occur and patients could die or they could be seriously harmed. But it is important that we learn from these mistakes or processes. When you talk about these processes, people will talk about human error. So what is human error? Human error is what you see as the tip of the iceberg. But what you don't see are the processes, the culture, and other manifestations which lead up to the human error. It is likely that the human error is the symptom of the problem than the wider care system. It is important that we move away from being focused on the human error. Human error is a normal part of everyday life and even also in the workplace. And it is a natural condition and occurrence that enables us to develop, learn, and function. So morbidity, mortality-related learning and improvement, it could be more objective, meaningful, and effective. If we learn to move away from focusing on human error, but also focus on the system that led to these errors, I think we could increase engagement of professionals who deliver health care, the policymakers, the managers, etc., in order to ensure patient safety. Well, I work for Sheffield Teaching Hospitals Trust, which is one of the largest NHS organizations in recruiting 15,000 staff and serving about 2.5 million people in the area. But with this comes the challenge of having to deal with 3,000 deaths a year and 3 serious untoward incidents that Professor Fernando mentioned earlier. With this comes the challenge of having to learn from these deaths and ensure that the lessons are inculcated into the staff members and we prevent the avoidable deaths. To do so, we need to work as a team to put the pieces of the puzzle together to learn the lessons. So in this cartoon, you could see there's a river in the middle, and on top of the picture is the land that the process of managing after death occurs, and before the river are the processes towards the end of life before the patient dies. After a patient dies, the process of managing the death crosses over the bridge, and in doing so, sometimes the patient will go to the mortuary, or if there are any concerns of the patient's death, the coroner might be involved, the coroner's courts might happen. If there are no issues, then the relatives will bury the patient and then bereave. But before the death, there'll be doctors, the nurses, healthcare professionals like ambulance crews, the police, they would be involved. So it is important to remember that doctors' involvement is only a very small part. There are large processes involved around the patient's death. In resolving and understanding this puzzle, it is important to piece together different pieces of this puzzle. Structured judgment review of mortality is one piece in this large puzzle. Why is it important to review mortality? Is to be enabled to quickly identify concerns and feedback into the system to make sure that we don't do the same mistake again. We learned quickly that the one important piece of this jigsaw puzzle to bring the rest of the pieces together is to be able to learn from every death. Now, if an organization is of a certain scale, you might be dealing with a large number of deaths. So you might not have the resources and the manpower to deal with each and every case. So therefore, your department or the hospital might want to decide that you apply a certain set of criteria to study each death. So in my department, although we study all deaths, we ensure that we focus mainly on the patients who are younger, that's less than 50 years of age, those who have been electively admitted for procedures, and vulnerable people like people with mental health or learning difficulties and dementia. And of course, if a patient's family or the patient has raised a complaint during their care, we make sure that those patients are assessed carefully to see whether we have missed anything or whether we can learn any lessons. Learning from death is not something that is unique to Sheffield Teaching Hospitals. It is part of a national program called the National Mortality Case Record Review Program. And this program uses an evidence-based tool called Structured Judgment Review. And this allows you to assess patients' death objectively and generate qualitative and both quantitative data. This is what it looks like. It has two components. One is an assessment of the care of the patient that they received from admission to the hospital until death. In the initial admission, for the first 24 hours, mid, late, and overall care is scored out of 1 to 5, which is a visual analog scale. Now, when we analyze the patient's death, the reviewer is expected to give explicit judgment of what's happening. What is explicit judgment? This has to be based on the information at hand and whether to see the patient, the managing team, the professionals have followed hospital guidelines and protocols. In other words, it is like telling somebody, well, on the weather report it says that Colombo will have tropical shower tomorrow morning, so you're going out, I would advise you take an umbrella. That is an explicit statement. What is an implicit statement is your mother might say, well, son, you're going out, sky looks a bit dark, it's best to take an umbrella because you might get wet. Now, that is an implicit judgment based on some evidence, but you make up the story in between the lines. We encourage the reviewers to make explicit judgment based on evidence and the protocols in the trust or in the hospital. We also look at the avoidability of the death judgment. Now, this is scored between 1 and 6. 1 means definitely avoidable death. For example, patient comes for a knee joint replacement but dies of penicillin allergy, and the patient is known to have penicillin allergy, and if somebody gave penicillin, patient dies, then that is an avoidable death. Definitely not avoidable death is, for example, a patient who may be 85 years of age, suffering with dementia, presents with a large stroke, and patient dies of a chest infection in the hospital. Well, you need to look into this death, but still it might not be avoidable. So in between the scale are several other numbers, and it is based on the reviewer's judgment to decide whether avoidability is between 1 or 6. Every death that is scored as avoidable, that means between 1 and 5, will be very seriously assessed by the clinical governance team to make sure that what went wrong. So when we assess these patients, there are a number of themes and different data sets that are generated. And these, not only by, we don't stop at looking at the patient's death and analyzing them. When we figure out what are the themes which are generated from this analysis, these themes are then fed back into the clinical governance process. So the managers, the clinicians will be looking into improving the patient care standards based on this data. And as Professor Fernando said, this will generate certain audit processes to see if the existing care is in line with the gold standards published by the colleges or national body or international bodies. And it might raise concerns about, well, we might have to improve our transparency in care of our patient, keeping the family and the patient at heart. This might also lead to certain research ideas and innovative ways of improving patient care. And that is how you use the information generated by doing the mortality, morbidity assessments. In Sheffield, we have a mortality, morbidity meeting every quarter, and we have about 24 deaths every 3 months, and we choose cases to discuss. We don't discuss all the cases because that will bore the clinicians to death. So we select our cases based on whether they are young, whether they have any underlying problems like mental health disorders, or if the cause of death is unexpected. For example, if the patient was admitted for Guillain-Barré syndrome in the UK, you don't expect them to die. If they die, then of course you need to find out what went wrong. So let me give an example case. And this is a 79-year-old man who was admitted very recently to the ward, and he died after about 10 days. And his death certificate said he died of ischemic stroke, and death certificate comes in 2 parts. The second part said septicemia, secondary to urinary tract infection, and dementia. Most of my colleagues will say, come on, what is there to learn in this patient's death? He's very old, he's got dementia, he's died of a large stroke. However, as I mentioned earlier, this is a vulnerable patient, so patient with dementia, there might be lessons to learn. And this patient's REVIVA had given low scores. So based on these 2 factors, we decided to look at this case. So let me take you through the analysis. So, is that the pointer? Okay, so I don't know whether you can see. So this patient has had a couple of falls at home, and the paramedics were alerted. Paramedics went to see the patient pretty soon, and they had so the reviewer will assess the patient's assessment at the scene, and they documented that this patient was FAST negative. That means face, arm, speech assessment for negative for stroke. But they recorded the patient had mild temperature and was unable to get up, so therefore the patient was brought into hospital. At the A&E, it was assessed that the patient has a previous history of seizures, and probably this patient has had seizures, and that is why he has fallen. So the reviewer scores that the assessments were done accordingly, very quickly. The patient was assessed in a timely fashion, therefore the score of 5 is given, which is good care. And when you move on to the initial assessment in the neurology department, the reviewer only scored 3. And when you look at the reasons for that, the junior doctor who assessed the patient has taken the history from the A&E notes because the patient was aphasic, didn't give a good history. You are expected to be able to assess the previous medical notes or call the patient's family to find, or the GP practice to find out more information. This junior doctor didn't do that. And furthermore, the junior doctor decided to start the patient on an anti-epileptic drug at a dose that she saw on an old clinic note which says 1 gram BD of levetiracetam, when the patient was actually on 1.5 grams BD. Now this was recorded as unacceptable, and in the below point, the reviewer says that care could have been optimized if the person who admitted the patient took an extra effort to go and do a proper documentation. So this raises the concept of need to improve documentation. As Professor Fernando mentioned, this is an important aspect that we drive in our hospitals to improve documentation, and then also the junior doctor can't document if the notes are not there when the patient is admitted. So there are processes to improve availability of medical notes on the ward when a patient comes in. And then the next 24-hour care is assessed by the reviewer and doesn't give a 5 out of 5, but gives a 4, which is fair score. Now, why was this given? Why was this score given? It was found that the patient's brain scan or MRI scan showed multiple strokes. Registrar has done a fantastic assessment and initiated the initial treatment. However, it was found that the consultant who was on call hadn't seen the patient within 24 hours. Now, it is our hospital policy a patient who was admitted through acute admission should be seen by a consultant within 14 hours. So this patient's care, in that sense, was breached by the said consultant. So it was raised as a concern. And then when he came to the middle of the mid-care of the patient, it was found that this patient has developed tachycardia and respiratory signs, and the patient was running high fever. And then the team has recognized this very early and started the appropriate antibiotics. Now, this is good care. And we not only pick up on, we don't expect to pick up only the bad care, but we also celebrate good care and also feed that back to the team so that we celebrate achievements as well in the process of morbidity mortality assessments. When it came to towards the latter half of the patient's care, the patient suddenly drops the GCS, and it was found that this patient has had a large bleed. The team managing the patient initiates some palliative care processes, but does not involve the palliative care team until 3 days later. Now, in our hospital, if somebody was thought to be in the end of life, it is considered extremely important that the patient is kept distress-free, comfortable, and less agitated. One of the processes we do is by involving the palliative care team who are experts in managing this. So the reviewer says this patient's care is only 3 out of 5 because end-of-life care process was not initiated. Now, how has this helped? How has this patient's assessment contributed to care on my ward? We do audits regularly on these processes of end-of-life care, sepsis management, documentation, and sometimes the junior doctors are required to perform these audits as part of their training, and sometimes the clinicians who are concerned about patient care, who want to improve their standards and perhaps for their appraisal, there are various drivers for them to do these audits. And in one of the audits that they've done, it showed that not only this patient, there were several other patients whose end-of-life care was not improved or initiated in a timely manner. So this led to a departmental training day on end-of-life care and dealing with patients towards late part of their care. And then also there was a training program on advanced care planning. So this is how even an unavoidable case with dementia and large stroke has led to learning from their death and change management and practices on the ward. So in summary, this patient overall care was 3.5, even though on the outset it might have appeared as if there's nothing to really learn from this patient's death, although this case was an avoidable death. So when we regularly analyze these patients' deaths, we find that you could do various forms of analysis. You could do certain thematic analysis, or one of the simple analysis is a word cloud analysis of the different statements the reviewers make. You could see that when you look at the initial admission phase, the words like good and plan come as big, and some of them are appropriate. So it is encouraging that we may be doing well. Having said that, we still also see statements like poor. I like to see this poor in a much smaller font in going forwards. When you look at the end of life phase, the words like good care come as very big. That means we are doing fairly well in those spheres. But still, the words like palliative care appears very small. That means we need to increase our awareness and engagement. So common themes that arise from analyzing these patients' deaths are the opportunities taken or missed during the patient's admission. And early warning score recognition is an important part of managing our patients. Senior review and case review timing and the fact that they need to be delivered on a timely manner is important in our department. So there are various themes that are generated, and then this can lead to sets of data sets we can look into, and we then inform the clinical governance process and saying that there's a problem in this department for antibiotic prescribing, or there is a problem in this department that the consultants are not reviewing the patients in a timely fashion. So then the processes can be put in place to improve such failings. So it is not easy to, as Professor Fernando said, herd a group of consultants and junior doctors to engage in clinical governance process, because there's a tendency to believe that this is only for managers. But if you are interested in improving patient care and safety, then I think you will want to engage in this process. So resource allocation is a big problem because none of us are paid to do this. So we do this in our own time because we want to improve patient care and safety. And there are sometimes competing interests in the department. For example, if I have an M&M meeting or an audit meeting, somebody will say, can you please give it up to allow a professor from Mayo Clinic to give you a talk on polar bears in Arctic. So you'll be asked to give up your slot. So you'll have to fight to ensure that we have time to disseminate the knowledge that we learn. And the other challenge we face is that when we identify problems, how we're going to plug that into the clinical governance processes. And there are barriers to that as well. So in summary, I would like you to consider learning from deaths an important process to improve outcome for your patients. And a standardized tool exists called structured judgment review tool. This can be, you can modify this the way you want to use in your hospitals. And this will generate qualitative and quantitative data sets, which then over time you can look into see whether there are any themes. And I fully appreciate that this is the model that we have chosen, and there are loopholes, and one size does not fit all models. And I'd like to thank the following people and also the Royal College of Physicians for sharing some of the slides. And I'm like Prof. Fernando, I'm very happy for you to use my slides if you want to. Thank you.
Thank you, Dr. Hevamatthama. I thank both the speakers for sticking to the times that they were assigned for. And then that leaves us with another 5 minutes for questions. And the floor is open for questions. I'm sure the erudite speakers will be more than happy to answer your queries. May I get the ball rolling? Yes, okay. Sorry. Can somebody, the lights are white. All right, okay.
Yeah. Could I ask whether the information generated through these structured judgment reviews, is that information confidential? Does it get into NHS system? Because I asked this question because in Sri Lanka now we have a Right to Information Act. So is there some kind of regulation similar to that in the UK? Or is the information completely confidential so that the participants can be free of in litigation?
So one of the important aspects in clinical governance is transparency, and there are problems certain trusts faced because they covered up incidents. But your question was more about learning from themes. So teams do not have patient identifiable information, but we do discuss the patients openly in the department. It has been raised by the information governance teams in my hospital. Well, can you discuss and circulate information relating to patients? Well, there is a slight risk on that, but we have accepted that risk, and the information is only circulated within the people who are involved, because there is no other way to learn from the mistakes. But the themes generated can be discussed widely, and they do go on to what is called a trust dashboard. If there are serious untoward incidents or failings, the department is expected to put that on a dashboard, which sometimes can be accessed publicly. Sure.
If I can just add, the Data Protection Act is applicable, so there's nothing secret.
When it comes in Sri Lanka, the patient care, roughly, outpatient, 80% in the private sector, 20% in the government sector. But when it comes to the inpatient care, 80% in the government sector and 20% in the private sector. So we do the bulk, and we do in the government sector, we do a great job. Only thing, we get criticism, things happen place to place, and the newspapers, they highlight those things. So we feel that by doing little changes, something to similar to what you mentioned, we can prevent most of the things. I think we can prevent the majority, because we do the hard work, and eventually sometimes the doctors get the blame. So as you correctly said, it's a teamwork, and it's not only the doctor. There are lots of people involved in those things, and they don't get the blame. It's eventually end up with the doctor. In our country, when it comes to the jobs, when there's a duty, it's the nurse, doctor, and the ordinary staff, mostly appointed by the politicians. So when they come to the hospital as kind of it's a junior workers, they have no idea. They are coming to a hospital and they are handling with patients. It's just a job for them, for supporting the politicians. So when we start this kind of things like clinical governance, we have to educate from top to bottom, the doctors up to the minor staff, that we are handling patients and it's a different entity. And I think we have gathered a lot from you guys, and lot. And we can do that, because that if we can work according to the international guidelines, and we can work according to the international standards of medicine, why can't we work according to the standard clinical governance? So we also could do that. I think it's a good topic, and it's an eye-opening topic. And Ministry of Health, we have a separate quality secretariat. They are trying to improve the quality in the health government sector in this country, and generally support is good. So I think it's high time we all should get together and get your experience to our system and try to improve the quality in our system.
Can I just respond there? A few things about that. You use the word blame. So the most important thing is to create a no-blame culture. In terms of the ministry, the habit of transferring doctors for punishment is something we don't have in the UK, so that's something that needs to be looked at. And the difference between the private sector and the public sector, well, when you notify things, when you have a system, you identify problems. So actually, if you look at the NHS and some of our hospitals, we seem to be the worst places for delivering medical care in the world. But is it perhaps because we report it? Is it because we are transparent? So that is something we need to look at. Certainly it needs to be improved, but lack of reporting merely hides the issue. It doesn't mean it isn't there. And lastly, to your comment about the quality secretariat, it's part of a cunning plan, as Baldrick would say. We have trained people in our own hospitals, and certainly Sridharan Sathasivam, who's the Deputy Director General Planning, spent a year with us, and Uppuli Vijayamana, who is, I think, going to be the next Director of Quality Secretariat, just finished training in Sheffield, where all this stuff goes. So there is something to build up with the College of Medical Administrators if there is the ability to work together.
We'll take one final question.
Thank you, sir, for answering part of my question, which actually what I wanted to know was, you spoke about the no blame culture. We as trainees, we have been dealing with mortality morbidity reviews, but then again, when we do mortality morbidity reviews in the ward setup, or I mean, my colleagues would answer, certain places where there is sort of like a stigma, even with your seniors, your superiors, the bosses thinking, okay, is this trainee substandard or something like that? Is there, like you answered part of it, how, is there any practical way to, you know, get this no blame culture into our medical culture in Sri Lanka?
Let me quote something that you will appreciate about casting the first stone. I'm sure you'll appreciate that comment more than anybody else, because you use biblical quotes all the time. So I think none of us are free of these faults, and we do need to reflect honestly on our mistakes. Reflecting on our mistakes does not make us substandard. I hope that answers your question.
Right. Thank you very much. Then that concludes the symposium. May I invite Dr. Priyankara Jayawardhan, the Vice President of the Sri Lanka Society of Internal Medicine, to come and hand over the certificates.